Hi, everyone. Before I start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories all of our work takes place. So my name is Autumn Sipis. I am the Marketing and Outreach Coordinator with the Canadian Coalition for Green Healthcare. And on behalf of the Coalition, Peach Health Ontario, and Cascades, I would like to welcome you to today's webinar, Pharmaceuticals in the Environment, Impact on Non-Target Organisms. Throughout the webinar, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation. And our speaker will be answering questions at the end of the webinar today. This webinar is also being recorded, and it will be sent out to all registrants and available on the website at a later time. The slides will also be available as well. And now I'll hand things off to the Executive Director of the Coalition and Partnerships Lead of Peach Health Ontario, Miles Sargent, to introduce today's topic and our speaker. Take it away, Miles.
Thank you, Autumn, and hello, everybody. It's a beautiful day in Ontario, just shutting down here, but gosh, what a great day it was, springtime. And we have exciting times in sustainable healthcare. There's a lot going on, and there's a lot of webinars happening. People are rising up and realizing how much there is to be done and how much we can do collectively. Polypharmacy, as we've known for a long time, is a problem for our patients. It's clearly a problem for our health system. Dr. Hale did a talk a week or two ago about polypharmacy and deprescribing, which was very well received. And we also talk a lot about the greenhouse gas emissions of medications through their production primarily. Tonight, we're going to be taking a bit of a different angle, which is looking at drugs as contaminants in the environment. And this is something which Gigi has been thinking about doing projects on dating back to 2010, which is unusual. A lot of us are newbies. And here's Gigi's bio. Gigi is a pharmacist in Vancouver, BC, who strives to increase awareness of pharmaceuticals in the environment and to inspire others to take action toward greener pharmacy practices. Over the years, Gigi has dedicated her time to endeavors which advance this cause. Gigi is the pharmacist for quality at Lower Mainland Pharmacy Services in Metro Vancouver, which encompasses 4 health authorities. Her work focuses on supporting 25 hospital pharmacy sites toward compliance to new standards for safer sterile drug preparations for patients. Gigi's humble. I think there's more things she could have added. I will add that she's also a member of the Coalition's National Sustainable Prescribing Working Group and is an advisor for the Coalition. And here's Gigi.
Thank you so much. I'm so grateful to be here to get to share about this topic I've pondered a lot about. Just a prompt that if you could have your smartphone ready, it is going to be an interactive session, and I'll give more directions in a moment. And this talk today is actually catered towards prescribers or healthcare professionals that administer medication or dispense them or do clinical work, so pharmacists. And so it's a little bit more detailed than another similar talks that I've done in the past. All right, so let's get started. So grateful to be here with the Coalition, Cascades and Peach. So very excited. So the learning objectives for today will describe how pharmaceuticals enter the environment. I'll give one example of wildlife negatively impacted by pharmaceutical use in our society. We'll be familiar with the environmental classification of pharmaceuticals after this webinar and understand the precautionary principle. My own objectives is to inspire action. That's my own personal objective, but for your takeaways, these are the ones. And so today's, if you could get your phones out, the QR code's the easiest way to get in to participate. I'd love it if you join. One thing is to enter your real name or a nickname, and be mindful if you use a nickname to choose a webinar appropriate nickname, because if you are one of the leads at the end, your name will pop up. So be mindful when you choose the name. And only if you've never done this before, only the question we're talking about will show on your device. And it may take just a moment to load. Okay, so this is the warm-up activity. I'm hoping we could just get our users familiar and in the system. So the warm-up is list me some things that are green in color. If there's anyone that could join in, that would be lovely, so that we can get things going. Trees, grass, forests, all naturey things, plants, limes, yes, all chlorophyll full of great, excellent. Algae, leaves, trees. Okay, thank you. Avocados. This is just kind of warm up to the platform, so it's very nice. Emeralds, love that. Okay, so I'm going to move on. Okay, so now you're all warmed up. Excellent. Now I'm going to go into more of the context about the talk. So with Planetary and healthcare in the link. So just hot off the press last week, there's the updated report with the International Panel for Climate Change, and they have some messaging that's very strong wording about devastating consequences. That's probably not new to the group that's tuned in, about how we have to act now to alter the emissions. And that is one piece of it. And concurrently, maybe not as much until recently, is that healthcare also has a climate footprint. And so there's a lovely publication here you could also look at in your time that you have on these pursuits. But the link that I want to talk about with the healthcare, how we contribute to the climate crisis, I really like this picture. But basically, we have the direct emissions from the things we do every day, but also the things that we use to provide the delivery of care also consumes and as a consequence emits more greenhouse gases that cause the effect. And then there's downstream effects of other things like how we manage the waste, say pharmaceutical waste or medical waste as well. But the link that I want to also pinpoint is Canada's piece in it. So if we actually look at role in planetary decline, actually the healthcare sector accounts for 5% of all emissions, and of which, when compared to 47 countries, Canada is actually the third highest per capita, which I was really shocked about when I realized this. So of course I felt it was a bit upsetting, but those were the stats. And then of this piece of the contribution, pharmaceuticals actually account for 25% of the healthcare carbon emissions. And in fact, medicines are 20%. And then, as some of you are familiar with, or perhaps not, the propellants in the metered dose inhalers, also called puffers, as well as anesthetic gases, are so considerable that they actually have their own category in the pie graph. So that's a huge chunk of the contribution is pharmaceuticals. And another really interesting diagram, England in an assessment, is that medicines are actually, it's a circle point graph where the size also reflects the proportion of its contribution. So the most of the use of the medicines and chemicals are in acute care and primary care settings. So what I want to talk about is that pharmaceuticals pose a unique risk. So there's different aspects to the topic. Some would think about the physical waste from dispensing the medication, the packaging, the medication vials, the ice packs, the styrofoam. Or some would also think about the global warming potential from the gases. But this other aspect is not talked about as much, but it's the drug itself, the active pharmaceutical ingredient that elicits the biological effect, which is the focus of this talk, which is the piece that I will be talking about. So drugs are unique risks because they are taken to cause a desired effect in the target organism. And the effect you want, usually for therapeutic use, is a physiological effect. And humans share a common physiology with other living things. And it's the reason, if you think about it, why animals are used in the experimental phase in pharmacology in the early stages of drug development. Usually it's mice or rats, and in later stages, they're rabbits, dogs, cats, or non-human primates. And the only reason that makes sense is because you want to do some preliminary testing to see if the drug seems promising, which means that we have to have a common biology for that even to make sense. So they're very unique risks because of that. So this is warm-up number 2 before we get into the actual quiz is, as an exercise, what drug, if you could put it in generic name, do you use the most? Use could be you prescribe to patients, use could be you administer to patients, or use personally, or if you're a pharmacist and you do dispensary work, what do you dispense the most? Acetaminophen, yeah, same as acetaminophen. Tylenol's coming up a lot, metformin. Yeah, ibuprofen, some ACE inhibitors, more NSAIDs, some opioids. Very interesting. So Tylenol's coming up first, acetaminophen, apixaban. Great. Thank you so much. So that's actually very interesting to see kind of what people use, because that might give you an idea of what might be in our environment. Okay. I'm going to move on. 2 more seconds for contribution. Thank you so much. Okay, so that was your warm-up. Thank you for participating. So moving onwards is that then it links into the angle about why pharmaceuticals also pose a risk in addition to the climate is the concept of thinking about the planetary boundaries, and there are 9. It's another model to think about planetary health. And it's about boundaries that we need to maintain to thrive. And if we cross these boundaries, it would cause large-scale, abrupt, or reversible changes. And humanity has already exceeded actually the planetary boundary for environmental pollutants and other novel entities. And that's up here on the right where the arrow is. And so here's an example of one of the graphs in this article, and it talks about pesticides. And if you think about pesticides, it also is a drug, except the target organism are things you don't want, which is the pests. You want to get rid of them. Another example that they've graphed is antibiotics, and that is also increasing as well. And so it's defined as there's chemical pollution, but it could also be new substances, not just drugs, but other engineered chemicals that we haven't even emerged, and that even if we reduce the production of them now, the persistence of those that have been already entered the environment continue to be a risk. Okay, and so it's a loose umbrella term. Pharmaceuticals are one of them, but also it includes, just for comprehensiveness and accuracy, personal care products like all the perfumes and fragrances or hairsprays, as well as chemicals that like we use in industrial settings. And that whole cluster is the novel entity, which is causing the chemical contaminants. Okay, so now I want to talk about how one of our objectives is how do they enter the environment? And so this is when the quiz begins. And so question number 1 is, what do you think is the main route of entry for pharmaceuticals in the environment? A, flushing unused meds down the toilet or sink in the household. B, unused medication from expired, excess, or ineffective meds. Or C, through urine and feces after human consumption. Or D, manufacturer factory wastewater. Okay, I'm going to give 10 more seconds to vote. Five more seconds. And let's see what we got. Okay, time. So most people Yeah, so we have a bit of a distribution here, but most of you pick urine and feces after human consumption, and that is the correct answer. So the main route of entry actually is from human use. And if you've never thought about it and you're not a healthcare provider on this webinar, if you thought about when you take a med, where does it go? The most common route actually is it gets metabolized. Most of the time, the majority is by our kidneys, which then it gets excreted in a urine. Some of it is in our fecal matter. And it may be excreted as the original drug, or it may be metabolized into something else. And those metabolites themselves can be active or inactive. And the sewage plants are actually not designed to remove drugs, although they may be removed in the process or destroyed in the process, but they're not designed to. And so it enters the environment through our sewage effluents, which means the water's leaving the sewage wastewater treatment plant, and that's how it enters our surface waters. And so the more drugs that are taken, the more that's excreted and the more that will enter. So this diagram depicts it very well. In our homes, we flush it, and then it gets through the sewage system, may not be gone, and then it enters our environment that way. So I would like to talk about the first example of the organisms that are affected, which is birds. So the story is about vultures, and there are 3 local species of vultures in Southeast Asia that were negatively impacted by the use of drug in society. And there are 3 species. They were the white-rumped, the long-billed, and the slender-billed vultures. So the second question that I have for you is, what % of population decline do you think was observed in these vultures after 15 years? 50%, 75%, 90%, 99%, or 99.9%? Give 10 seconds to vote. Okay, time. So most of you picked 90%. Okay, so the answer is 99.9%. And this is the story actually that got me into really caring and advocating for this topic. So one of the most abundant birds of prey in 15 years, a drug, which I'll tell you shortly what it is, was responsible for killing 99.9%. If you look at this log graph, it happens very quickly. And it's actually kind of mind-blowing. And I have to say this, when the first time I learned about this, I was horrified. As a pharmacist, it wasn't taught in school about some other impacts of drug use. And it really kind of got me into this, marathon commitment of trying to advocate for stewardship for drugs and the environment. So you might be wondering what killed them. So what drug class do you think killed the vultures? So it's A, antibiotics, B, antifungals, C, analgesics, D, hormones, or E, antidiabetics. Give 10 seconds. Okay, so time. Most of you voted for analgesics. And yes, that is the correct answer. So the drug diclofenac is a medication that's also found in Canada that's used for pain, fever, and inflammation. And it's a non-sterile anti-inflammatory drug, which we call NSAID for short. It is used in humans with prescription for tablets. And then you can also get it without prescription in a topical gel format. And it's also used in agriculture, in livestock, due to its common physiology, that we could also use them in animals. So next question I have is, how do you think the drug killed the vultures? Option A is through a gastrointestinal bleeding, B, kidney failure, D, delayed wound healing, or C, delayed wound healing, or D, unknown. Okay, 3 more seconds to vote. Okay, so B, kidney failure. Actually, this crowd is very, very knowledgeable. Yes, kidney failure is the correct answer. So a very well-known adverse effect of this drug class is kidney failure. And vultures actually ate the dead carcasses, and the kidney failure actually caused a uric acid buildup, and they also got visceral gout in their internal organs. This is a photo of an example of vultures that have died from the dose that was reflective of diclofenac in the cattle that when the researchers were investigating the cause of death. Okay, so I wanted to, just as an exercise, I thought it would be interesting to compare the human versus the what kind of dose killed them. And I do acknowledge that the pharmacokinetics in different species could be different. So the way we absorb, how it's distributed, metabolized, or excreted could be different across species. In fact, we don't even study that, so we don't know. But as an exercise, I thought it would be interesting to know per milligram per day, like what type of dose killed them. So the maximum therapeutic dose in humans is 150 milligrams per day. With an average adult of 70 kilograms, it equates to 2.1 milligrams per kilogram. And in contrast, the lethal dose to the vultures was 0.1 to 0.2 milligrams per kilogram, which means that a 5 to 10% of a therapeutic human dose is the 100% lethal dose in vultures. And this graph, for those who of you are not familiar with this graph, and if you've wondered where doses of drugs come from, this is a classic example of we take the effective dose, and there's a curve, which means 50% of the organisms it works, and that's the dose. That is where the doses come from. And then there's another curve, which is what dose do you see a toxic effect? And then the curve on the right that's in red is the dose that is lethal, which kills the organisms of interest. And so that means that if this diagram, this basic diagram, is the diclofenac diagram, for example, or whatever the drug in general, we use this diagram as an example, it means that the lethal dose of the vultures is almost straight up. And I think that the diagram is very impactful because I think it really shows how little that we know about all the other organisms that are out there that's not studied. And this one we know about because they're literally all dropping dead within a very short period of time. And I think it's a very impactful exercise, I think, to think through. Okay, so vultures was our first example. Now I want to give you a second one to take away with is fish that were impacted. And so this is about flathead minnows. It's a Canadian study. I thought it'd be fun to use a Canadian example in Ontario. And it's a 7-year whole lake experiment. And it is the work is completed in a place called ELA, which is Experimental Lake Experiment Places. Is established place where these little lakes in Ontario are these pristine lakes, and it's actually been established where you can actually study the impacts when you change the lake or add things to it, and you study the organisms that are in certain lakes. And it's actually kind of an internationally recognized a place for this type of cutting edge work. And so the fish were exposed to estrogen. And my question for you is, how diluted do you think the estrogen was in the lake that mimics the concentrations that is observed from wastewater effluents? A, parts per million, B, parts per billion, or C, parts per trillion? I think this exercise is just to appreciate how trace are we talking about? Just to appreciate this piece. Okay, 5 more seconds. Is any late voters? Okay, so time. Most of you guessed parts per million, and then the next highest was parts per trillion. The units are actually in parts per trillion, which the exposure in the estrogen is a chronic dose, chronic concentration in the water. So it's 5 to 6 nanograms of estrogen per liter of water. And if I flipped it around, it means there's 5 to 6 grams in 1 trillion liters of water. And the synthetic estrogen that is in the research project is the common estrogen found, synthetic estrogen found in birth control pills. Okay, so I think this is was a nice exercise to really see how trace are we talking about to actually have an impact on organisms and what happened. So the next question I have, question 6, is what happened to the fish when exposed to estrogen? A, the fish had larger fat content. B, the male fish became intersex and started having eggs too. C, the reduced ability of fertilized eggs to progress into offspring. D, almost to extinction. And E, answers B, C, and D. Give you 10 seconds. Okay, time. Most of you guessed the last answer, and the last answer is correct. It was very sad when I learned about this story as well, and it was one of the ones I wanted to highlight. This graph here is a figure from the paper, and the left here is a control lake that did not have the added estrogen, and the right side here is the lake that was added the estrogen E to, is the ethanoestradiol synthetic estrogen. And if you look at it, by the time when it was added to the lake in 2001 to 2003, and then when it was sampled in 2004, 2005, there are almost not even detectable number of fish left. So the fish were basically, it's quite a sad graph if you understand what you're looking at, pushed to almost extinction. Okay, so I would like to talk about example 3 and also share that non-target organism can also be humans that are impacted by its use. And so the part 2 of the vulture story is actually sky burials were actually halted from broken cultural traditions. And so the Parsi and Tibetan Buddhists actually rely on the vultures to consume the human remains. And because of due to geography, they couldn't bury the remains in the earth. They didn't have trees to burn or do cremation. And also they were not near a river or ocean. So that was the way that their culture had evolved into processing the human remains. And so the vultures are actually considered very sacred and sent from divinity, and it enabled the circle of life. And it really respected life to then be lived and serve and have others then sustain the circle of life. It was actually perceived to be very beautiful. And so my next question is, what other impacts did this lack of vultures have on the local people? The first one, accumulation of human remains and stench, increase in feral dog populations. The third, increased rabies transmission from dog bites. The fourth, trauma from broken cultural traditions, or D, all of the above. Okay. 3 more seconds. Okay, time. Yes, this one I think was an easy one. So unfortunately, it just keeps unfolding. And so not only are cultural and emotional well-being impacted with the broken traditions. There's also a public health risk to the human remains that are accumulating, which is attracting the dogs and the growth of those dog populations, which is increasing the interface of dog bites and transmission of rabies to the local people as well. Okay, the next part of the talk is about whether there's a tool to help environmental classification of pharmaceuticals. And so there is, and I was super excited as a pharmacist when I first learned about it, and it started in Sweden. And they began analyzing water samples for active pharmaceutical ingredients, APIs. And in 2005, the industry began to conduct some assessments. And since 2006, they've actually ongoing updates and revision to the database. And so it's actually evolved. It used to be PDF, but it's evolved into an online database that you can put the drug into. And it is voluntary reporting though. So not everything's on there because they're not required to submit this information, the manufacturers. And there are many things that are missing, but it's a nice, exciting starting point that some things are there. So, and now how are the risks assessed? So it's by two ways. So the first way is the risk could be significant, low, moderate, or high. And it relates to the likelihood of the toxic effects on aquatic organisms by comparing exposure and toxicity. And it's also exposure is based on how that pharmaceutical is used now or its expected use if it's a newly approved one. And the increase or decrease of risk will change also with how it's used. Another piece of this scoring system is the hazard score. And so it's scored out of 9, and it's on 3 characteristics. Persistence, which is assigned a value of 0 to 3 for all of these 3, is its ability to resist degradation in an aquatic environment. Bioaccumulation is its accumulation in adipose tissue of aquatic organisms, and toxicity, which is the potential to poison aquatic organisms. And I thought as an exercise, it would be nice to loop back to what the diclofenac classification is. And the excerpt here is there's actually no score, which again shows, I think it doesn't have everything in there. It talks about how it's slowly degraded. It's not expected to bioaccumulate. It has moderate chronic toxicity. And then risk, it has a huge blurb below. And it talks about that diclofenac and those pieces that I talked about. And in addition to a scoring system for things that don't necessarily have a score, there's also other commentary, like there's a whys list. So this diclofenac is on the whys list about why to not use it. And in fact, it also, the problem is continuing, whereas there's eagles that are also suspected to be impacted. And not only that, now in Africa, it's observed the impacts are also happening similar to the vultures there, and some vultures in Europe, and some parts in Spain. And it's just like this cascading effective ripple effect in society. And so this is a very useful tool. It's a great place to look and a great place to start. But the emphasis is that the lack of a data doesn't mean it's safe. Just because there's no number here or the manufacturers didn't submit it or we don't have numbers to issue a score, that does not mean that the drug is safe, as demonstrated in the diclofenac tragedy. And so in summary, for this part, we've talked about vultures with the diclofenac, things in the sky, they died, things in the water, minnows exposed to estrogen, that's a prescription medication. Diclofenac is OTC and prescription. And the fish had intersex fish, all these other reactions we talked about, and almost extinction. And the humans are indirect, but we are still impacted about all these broken traditions, can't bury the human remains, increased population risk, health risk of transmission of rabies, and the ripple effect of all of these things afterwards. So I'd want to talk about the precautionary principle, which is that the lack of data does not mean that it is safe. And if you have that situation, you can use the precautionary principle to guide policy and to justify action in times of scientific uncertainty when the harms are considered serious and irreversible. And it also allows preventative measures to be taken even if definitive data in humans is lacking. And it's actually a recognized and supported principle by the Government of Canada since 2001. And so I thought with this target audience, I could have a few comments about what one can do. I have some brief comments, is just to continue to be stewards, and not only for the patients, but also for the environmental and therefore population health. And as you've heard in other probably webinars recently, that's all been explosion of interest in this topic, but to minimize the use. And so whether it's suggesting non-drug measures to start, such as social prescriptions, or spending time in nature, for example, as well as continuing other health promotion and wellness, and to reduce polypharmacy through things like deprescribing, which is often the case is when you are proactively optimizing medication or rationalizing, most of the time you're deprescribing. And also if you're a prescriber, add a duration of therapy is very helpful to only have the patient consume for the duration that you want, and remember to add it onto there. Other ideas is if you're just changing medication, have short, like don't write super long repeats. If you're just trying it out so they don't have stuff that doesn't work, you make sure it works before you fill a larger prescription. And in general, healthier patients, less drugs, less consumed, less peed out, less enters our shared environment. And just a few brief comments for any executives or directors or leaders of our systems out there. Become the leaders that we need. If we haven't had enough climate leadership in your organization, could you be those leaders? And if they're not around, then could you become them? And then can it be on every agenda and every decision so that we can move that sustainability, healthcare, and shift the organization into where we want to go instead of having it drift into a direction we don't want it to go. And then maybe sustainable healthcare change projects or QI projects could be a requirement, and an expectation that we all actively try to do something in a structured way so we can see if it's having an improvement or not. Can it be in a KPI, key performance indicator, in your organization? And of course, we need to dedicate resources of staff and time, whether part of their role, because it's hard for staff to do their full-time job, to do extra things, but have protected time for them to do this important work, are my ideas. And then I do have time to go over our key messages. Just to recap, is that so in addition to the climate crisis, stewardship of planetary boundaries is important for planetary health. Also, healthcare has a climate footprint. It contributes to 5% of global emissions, and within this, pharmaceuticals contribute to 25%. In addition to a carbon impact, pharmaceuticals pose unique risks as chemicals because they cause a biological effect on other living things. And although pharmaceuticals are used to benefit the patient, the reality is that it becomes contaminants in our shared environment after the patient use. Where drugs are consumed, it will enter the environment. The main route of entry is from human use through excretion in urine and feces. Diclofenac killed 99.9% of vultures in 15 years. It's a tragedy that illuminates how little we know about the impacts of pharmaceutical use on non-target organisms. And these impacts are relatively unknown because drug research does not evaluate the impact it has on all the other living things when it enters the environment. And last page of key messages is that it is incorrect to assume that chronic low-dose exposures have no impact. No definitive data does not mean no harm to wildlife. Exposures could be acute or chronic, high or low doses, with the vulture acute dose and the fish chronic low dose examples. There's a useful tool you could start, the Swedish Environmental Classifications of Pharmaceuticals, and to apply the precautionary principle for stewardship when the harms are expected to be great and irreversible. I have listed the Swedish tool here for, I think that would probably be the most interest to the group. There's a also cute video I really like for inspiration if you would like to check it out. The references in this talk are here. And the last question I have for the group is, are there things that you can do to reduce pharmaceuticals in the environment that you think you can do? Anything. Okay, 5 more seconds. Oh, I'm so glad. I was worried somebody would say no. There's more of an exercise of fun. Yes, I agree. I think everyone can do something. It could be as simple as, you know, taking your leftover meds to proper disposal, which was not the focus of this talk. Or if you're a prescriber, you know, making sure you add a duration of therapy to things to be reassessed. And the first one, the person, whoever put doctor, is number 1. So congratulations, doctor, whoever that was. You should have that on your phone. You got the highest 6 out of 8. And the last comment I have is, to close before questions and comments, is I hope that when we see one, for example, this beautiful tree swallow here, it's one from a healthy population that's thriving, and not one from a few on the brink of extinction. So that concludes my talk in the material. Thank you so much.
Thank you, Gigi. That was great. I had seen the talk before, or a similar talk, so I didn't participate. So whoever called themselves Miles, maybe there's another Miles out there, or maybe they were just someone pranking me. They spelled the name wrong. Yeah, look, really wonderful talk. It makes me realize it is something I don't know a lot about, something that we don't learn much about at all as physicians. I'm not sure about the pharmacy group here. I'd be interested to hear. Gigi, have you had a chance to look at some of the questions coming in?
Oh, no, I don't.
There's a couple chat questions coming in. I assume everybody can read them. Number 1, thank you for the great presentation and advocacy. Any recommendations on KPI to follow related to pharmaceuticals and reducing on carbon footprint of our pharmacies?
Oh, I think this one might be a controversial one.
Okay.
I think we should track proportion of waste, which I'm not sure if that's popular or feasible. Like I'm not even thinking about feasibility. I'm just thinking about what is it that we're trying to achieve. So the ideal world, okay, now we're talking about like excess. So the first is health and wellness. So people are consuming less, then we're not peeing it out and, you know, entering the environment, which is the primary. But if we're talking about excess medication for disposal, which accounts for about 8%, that's documented, of the total contamination. Manufacturing is the 2%. If that 8%, an ideal world, all our drug distribution processes in healthcare, it should be 0 waste. Because waste, to me, is showing that there are some inefficiencies or things that are causing the waste, and whatever those waste is. So if we could, maybe there should be benchmark, like, I mean, just kind of throwing it out there, but maybe like track the waste as a requirement. And of that waste, it should be like benchmark as like not more than, you know, X% of the things you dispense. Because if you're dispensing 100 units of drug and you constantly see that 25% comes back, I think that's a good one, personally, because ideal systems is the same thing, right? Like if you're making 100, you know, sandwiches and you're throwing out 30, you'd probably adjust something's not right? So I think that's one. There are many ways to start, but that's like one thing. I don't know if it'll be popular because it'd be sensitive and there'll be all these systems you have to look at that create that waste. But I think there's a lot of opportunity.
Again, this is that's sort of a pharmacy question. How what is the rate of people returning meds? Like what do you typically see at pharmacies, and are there differences across the country?
Yeah,
Yeah.
yeah, I'm actually can't remember off the top of my head. I could maybe loop back, but I know BC has a collection through product stewardship. There's collection and there's data on that. But I remember reading the survey results, and I don't remember the exact numbers, but when the survey was completed, a lot of patients actually just flushed their meds down the toilet, which I was completely shocked. And hopefully, at the very least, with the unflushable campaign that some of you may or may not be aware of, like it's like don't throw other objects in there that aren't supposed to go in the toilet, but medications was one of them. But I was shocked. I can loop back, Miles, if you want. I remember reading it somewhere, but I don't remember right now. But a shockingly large amount of people flushed down the toilet.
Okay.
Yeah.
Question number 2 by time. Looks like it is anonymous. Is that right? Is there any role for advocating for regulatory changes to include biotoxicity effects, non-human, for example, mandatory submission for new drug approvals?
That would be really great. Like, I agree that would be such an ideal world where if the manufacturers had to supply that information and Health Canada also approves it with an assessment of that, like I think that would be a great idea. I personally don't know how that would manifest. I don't know the process for Health Canada or how hard it is to change the regulatory requirements to require that. Or the con side is, would Canada be too small of a market for companies to even want to apply? Then it would impact access to our patients to drugs and the diversity of drugs that we have. So conceptually, it's a great idea, but I don't know the impacts of the profitability of selling their drugs on the Canadian market. I don't know.
Okay. I think I missed one. What is the toxic impact of vitamins and supplements? Since people sometimes might be attracted to consume supplements to remain healthy. I actually love this question because we don't often think about these items. We think about the ones we prescribe, and there's all the over-the-counter stuff as well, which might not even have great evidence, which is adding to the problem.
Yeah. I would say that, so specifically we're talking about like the active drug, right? So in the answer, I'm not accounting for like the bottles, the shipping, the greenhouse gas, the packaging, the labeling, the inks, not all that stuff. But if we're just talking about the vitamins, in the Swedish classifications, actually those are excluded because they have like the things you would put in a parenteral nutrition TPN bag, like vitamins, things that you're supposed to need for life that we would give to patients. Those are actually excluded, and they're not in the classification for that same rationale. However, when I was in the work that I've done reading the literature, I do know that overnutrition, like if you have too much nutrients, it also is a contaminant, which you don't usually think about. But if there's like excessive nitrogen or phosphates, for example, that throws off the balance, and certain microorganisms can flourish, and then that can cause other undesirable things in our ecology. So I think that there is that potential as well to like too much nutrient can also be a problem, because that's also throwing off the balance of the local, which is one of the lake experiments too, when I was reading it up, and all these cool things that they do at that lake in Ontario. But
it's kind of scary that they're using a lake to do that, but I suppose that's important.
Actually, I was very upset with it. It's also called like extreme. I think they use the word like extreme science. So they take, because I guess maybe in that Ontario area they have like 58 lakes, if I remember correctly, and they're all like individual. So they were like perfect little like experiments you could contaminate and test, which is very sad. but it's actually used it's like internationally like world renowned respected place for this work, which is quite sad and cool at the same time. But
okay, next question. I went to university in Holland, and we were taught that by the time the Rhine River got to Rotterdam, it had passed through 7 people on the way. Any studies that have been done on the effect of human populations downstream of sewage plants?
Interesting. The chronic low dose exposure of humans in our common exposure to the environment, that's the problem, is I don't think we have definitive data. But again, with the precautionary principle, it doesn't mean that it's not doing something. We just can't test for it. And I'll tell you why. It's because in the real world, you cannot, there's so many concurrent exposures of like plastic use, Teflon things, new shampoo, fragrances. You have many concurrent chemical exposures. And so in the real world, you cannot differentiate what caused it, because you're concurrently, like, you know, eating artificial flavored chips and drinking colored pop, and like there's so many concurrent things that you're consuming that you cannot definitively say it was that thing. And so I'm not aware, I don't even know how you could even do that study, and hence it doesn't exist because it's impossible to do. But for immediate adjacencies to sewage effluents, I do not know about human impact, but I do know that for example, effluents from manufacturing plants, of say there's a plant that had ciprofloxacin, and they manufactured ciprofloxacin, and there was a study to test the concentrations of the water that comes out of the plant. And I think, I don't remember the exact number, but I remember the magnitude. It was like 1,000 times the concentration you would use on the antibiotics to get the therapeutic effect. So I think the indirect impacts for sure is that must mean it promotes antimicrobial resistance in the local area where that plant manufactures ciprofloxacin, so that the local people, I would think that the resistant patterns, those bacteria would be very resistant to ciprofloxacin, and that they would have to use other fluoroquinolones or other drugs because of the indirect impact of being next to those plants that make those life-saving medication.
Nice answer. Do you like getting grilled at the end, Gigi?
It's fun. It keeps it interesting. I don't mind.
Okay, great. Okay, let's see. I got to scroll up here. Oh, I can't get to that one. Here we go. All right. This is a long one, so I might just do part of 3 because there's a few questions. Thanks for your wonderful presentation, Gigi. I have a few questions. 1, I am wondering if you had any opportunities to influence the reduction/elimination of single-use plastic packaging for medications that are distributed to patients in acute care in single film strips.
Oh gosh, this is a great question. I think I have to give context for the others before I answer it, if just take a moment. So I practice, I currently do project work, but I do serve the health authority, which is mostly from an inpatient hospital lens. And so for inpatients, in contrast to community practice, meds are actually packaged in, I think what the person's asking, and if I'm misunderstood, please just jump in and re-clarify, is the meds are packaged in strips. So if you think about like Halloween candy, like maybe this, your candy chocolates are in little packs of plastic. And in acute care, in most settings, one med is in one strip. Sometimes multiple meds are in one strip. Multiple different drugs are in one admin time, but most of the time it's one at a time. And that plastic packaging is very upsetting. I've heard this before, but I can tell you that when I tried to ask my contacts that about the strips, The answer that I got was kind of upsetting, is that apparently they tried to see who sourced it. The only person that makes the strip packaging was a manufacturer in Japan. And there's no alternative because it's proprietary at the time, that they couldn't even purchase like another person. So it was one of those problems that I didn't feel that we could solve. Even after looking into it, that was the answers that I got at the time. It's a bit upsetting, but I don't have the answer. I wish it could be different, but I think one idea I have is we start in things that you could change, that aren't as, taped up with only one person sells it, or it's proprietary to a specific machine that packs all these things, and start at places that there aren't those restrictions, because it's more tangible, and to get your confidence to doing those projects before we tackle like those other huge projects that would require like new contracts, getting the vendor to see who else makes strips. Then we have to buy new equipment to fit those in it. It's like a huge cascade of problems.
Okay, fair enough. So I'm going to go ahead to the next one. I'm just going to say, Gigi, I didn't ask you this, but we typically do stay on for a few minutes at the end, and we know people have to jump off at 9:30 to watch their favorite show or whatever they do. So people are free to jump off, but I will see how many more we can get through, and then hopefully you can stay on for a couple of minutes. The next one, have you looked at the impact of cytotoxic anti-neoplastics in the wastewater?
I actually haven't done much of that. However, with the slides, there is the link. And so you could put in all of the hazardous drugs of interest to you, and just to see if they have data on aquatic life. And again, the limitation to the tool is it's very focused on persistence, bioaccumulation, and toxicity in aquatic life, which is better than nothing. But it's just because it's not there, it doesn't mean it's not. And if you think about the mechanism of those drugs, you would think and hypothesize that those are high risk medication. And I don't know about the other places across Canada, but I assume it's very similar. We have like standards for hazardous drugs in the hospital for our staff to minimize their exposure to handling cytotoxic medication, hazardous drugs all the time. And in BC, there's a new policy about handling and all the PPE our staff might have to wear, and they've categorized different risks of it. So that almost seems like those are probably hazardous because of the mechanism of their toxicity. It's probably a good gut feeling, but it's not necessarily in the aquatic Swedish classification if the database or the manufacturers haven't submitted that information.
Okay. Gigi, you're good for a few more?
Yes.
Okay. Do you have example of pharmacist-led intervention that could help improve use of, quote, greener, unquote, medication?
I know in the past year or two, there's been a huge explosion of interest, and and these projects are like in progress, but I know that with the green inhalers, I don't know if this group is familiar, but a very short context is the metered dose inhalers that are propellant based, where they puff out like a mist. Those pressurized metered dose inhalers, the propellants, not the active drug, but the propellants inside are hydrofluorocarbons, and they have like a ridiculous greenhouse gas global warming potential, depending on the manufacturer. So it's not that the API specifically is the culprit, but it's the manufacturer and what propellants and how much propellant they put in it. And so with this amazing work, CASCADES, one of the groups that's done a ton of work, toolkits, and some and also clinicians I know locally, at least myself in BC, some colleagues I know about, as well as in Island Health, for example, are actively trying to lead some of this work to change certain patients that are suitable candidates to equally as effective and following the best practice guidelines using dry powdered inhalers that don't have that problem, or other inhalers that have a lower carbon footprint. And there are groups that are actively doing this work as well. And building these toolkits, Cascades, one of them. Cascades also has a piece on anesthetic gases. And I know other examples in hospital there's a medium-sized hospital in Fraser Health in BC that the anesthesiologists there have decided to not use the anesthetic gas that is the worst one, which is desflurane, and they at that site level has decided to all agree to not use it, and different stages of it. And in the prescriber work, a lot of respirologists, there's one that I personally know is trying to also shift the prescribing towards that as well here in BC. I can't comment on the other provinces, which may be doing amazing work as well, but I'm from BC, so those are the ones that I know about.
Are there any groups that are free to join in your area that you might type into the chat or tell us the name of? Are there any groups that people could join? And while you're thinking, I am going to give a shout out to Shaliza, who did a talk for us a few months ago. I did see her name on here earlier. I haven't checked lately, but Shaliza, or if someone in your group is still on, feel free to type in the CAF group if people want to join the Canadian Association for Pharmacists for the Environment, a fairly new national group of pharmacists looking at environmental impacts. Okay, so what about the effects of chemotherapeutic agents?
So I think I answered, the similar question earlier. So chemotherapy, cytotoxic, which I answered earlier. So I do agree, based on a lot of the mechanism, they would be concerning. And you can use the link that's in the slides to check all the specific APIs of interest to see if there's aquatic life data. But I do agree that that would be one that, is extra concerning, especially there's a lot of standards about protecting our staff from handling the medication, or, managing patient excretions through, as inpatients. And, that kind of makes you wonder, it's probably bad because it's getting peed and pooed out, and all these standards to wear PPE to protect you from it. So I don't have off the top of mind, but the list you can find in the database in the Swedish as a starting point.
Thank you. And I see that there's an attendee with their hand up whose name is Carla. I don't know if she can speak freely, or Autumn, if you need to release her to the webinar. And in the meantime, do you know of any programs to recycle or reduce waste with PMD inhalers?
The best is to take it to your local pharmacy for proper disposal. It's like the lesser of two evils. So the propellants cause the global warming issue. If there's residual unused, because if it's all out, then that's a different problem. But let's say you had residual and then you don't need it anymore, kicking around, and the propellants are still in there. Appropriate disposal, if they do it properly at the facilities, they follow these standards to a certain temperature of incineration. And even though there would still be greenhouse gas emissions from the incineration process, it actually changes the propellant, so it's less harmful. But it is an unfortunate situation that it's just the lesser of the two to take it there. And so in BC, there are lots of pharmacies, and there's a website you could go to with and find certain pharmacies if they accept it across. I would imagine, maybe Miles can comment, in other provinces or maybe in Ontario that something similar should exist for community pharmacies to take your unwanted medication. But it's just a tip though, do follow the request for popping it out in advance and do it yourself, because the pharmacies tend to be short-staffed and they don't want their staff to be spending time popping it out for you. So try to process it and just ready to go would help them out.
Yeah, I expect we could do much, much better on this end, couldn't we, in terms of disposal of things?
Oh,
Okay.
somebody answered the
Yes.
question. Marianne said in Ontario, they do have that program. So hopefully the other provinces do as well.
Okay, excellent. All right, so going back to that other question, which ended with the single film strips, part 2, are there any changes in the approaches through which staff discard of IV medications in hospital? I know often people discard medications in the sink. So discarding of IV medications in hospital.
Interesting.
Any approaches there? And by the way, I think we all know BC is ahead of most of the provinces in sustainable healthcare. So you folks are leading the way, but Ontario, we're trying to catch up, Gigi.
Okay. I think that's a good start. We're all trying. We have to try to shift the curve. But sorry, what was the question? I lost track of the question.
Yeah, sorry. It was any change in the approaches through which staff discard of IV medications in hospital?
Okay. I think so. Just from the what I was given, this is what I think needs to happen is the hospital needs to have a pharmaceutical waste disposal policy, and whether that's a pharmacy policy or a hospital specific waste segregation, waste management policy, there has to be one for the hospital staff to discard. And if they do have it, then it's the issue of not following the policy. Then those staff members could be educated on that and pointed out, I guess. But yes, I do agree for the intravenous medication, that is not the appropriate way to dispose. They're supposed to go in pharmaceutical waste for incineration, with the exception of, I know that things like TPNs, parenteral nutrition, some places don't consider that a risk, and you can cut it up and put it in the sink because it's nutrients and amino acids and things like that. But besides that, everything else should be in pharmaceutical waste.
Ariane has called me out appropriately, and she is pointing out that Quebec is also a leader in sustainable healthcare. She's talking about community pharmacies, but I know that that's true with SSE doing wonderful things. So the final one I have here, so again, in terms of discarding medications in the sink, therefore, from your experience, what is the best approach in changing behaviors around such practices and in making sure people understand that will not impair quality of care? So this is sort of a changing behavior question.
Changing behavior of
most of, well, I think this might be nursing. Would it not be, in terms of who is discarding, or pharmacy, nursing? I don't know who does discard IV medications when they're.
Yeah, I don't. Of course, it's all like unit or hospital specific. Sometimes the unique problems there, but I think that I would think most of the time for the units, it would be nursing staff or the staff that administer the medication. And most of the times then it might be an education piece. If all the policies are in place, the buckets are in place, you know, the waste segregation infrastructure is in place, then it's more about education. And yeah, actually, I think cutting it and putting it down the sink is more work than putting it in the drug bin. So that actually surprises me a little bit. But
all right. So I'm going to have a final comment here about our next webinars. And Gigi, is there any final comment that you want to make, or you want me to say my little piece first and buy you some time?
I'm just thankful that I got to share my topic, and thank you for having me.
Yeah, look, you did a great job, Gigi. Ivy Lamb is saying, IPAC advised for our policy not to dispose down hand hygiene sinks, even IV fluids without medications. Next month, we're still planning our talk for next month, but what we are planning on doing is the coalition is having talks mixed in with our other talks, that we actually invite what we would consider the sustainability champions in industry to tell us why why they are doing great things and why they are rated so highly within industry. And we're going to probably do our first one next month. As we all know, supply chain is massive. And so we need to see who's doing great things and learn from them. And then I think in May, we'll be doing a webinar with some nurses, probably about 5 or so nurses, talking about various issues that they're working on. So thank you, everybody, for coming tonight. Thanks, Autumn, and thank you so much, Gigi. That was really interesting.
Thank you.
Yeah, okay.
Good night.
Thanks,
Yeah, good night.
Gigi.
Yeah, good night.
Thanks, Miles. Good night,
Yeah,
everyone.
thanks, Autumn. Yeah, bye-bye.